A very good morning to all the participants. Am I audible?
Yes, ma'am.
Yes, madam. Audible, audible.
So, our today's session speaker, I welcome Sir Dr. Sai Krishna Tikka from AIMS Bibinagar, Hyderabad. I welcome you, sir, and thank you so much for giving your valuable time. And a very good morning to all the participants. I request all the participants to keep themselves muted throughout the session for the smooth ongoing of the process. We will be starting our session in 5 minutes.
Good morning, Sai sir.
Good morning, sir. Good morning. I'm just trying to share my screen.
Priyanka, are you there?
Yes, sir, I'm here. So, first we are starting our session in 5 minutes.
Okay.
Yes,
Sir, is my screen visible?
Yes,
yes
sir.
sir,
It
it
is
is
visible.
visible. Yes, sir, yes.
We'll start within 2-3 minutes, sir.
Sure.
Yes.
So, we are starting our session today. So, today's our speaker is Dr. Sai Krishna Tikka, AIMS Bibinagar, Hyderabad. Currently, sir is Associate Professor, Psychiatrist, AIMS Bibinagar, Hyderabad. Sir has completed Doctor of Medicine, MD, from Central Institute of Psychiatrist Ranchi. He is a life member of Indian Association of Biological Psychiatry, Indian Association of Social Psychiatry, and Indian Society. He has received awards, initiatives in neuroclinical research, initiative fellowship from Ministry of Science and Technology in December 2014, and many awards. So we are very proud and honored to have such a dignitary and eminent speaker with us. I request all the participants to gain knowledge from sir, and please keep yourself muted. Sir, I welcome you once again. Now it's on to you, sir.
Thank you so much. A very good morning to all the participants here, and indeed, pleasure is mine that I am, speaking to you all on this platform. It's not, very common for me to speak to engineers in general, but it's a great privilege to be speaking to you all. The topic that I will be covering during this session is intelligent computing for brain health applications for psychiatry. Some disclaimers before I go into the session. I'm basically like a clinician teacher. I'm a clinician by profession, and I'm a teacher. I teach in medical school. I have a keen interest in research and in cognitive neuroscience specifically. It's been exactly around 14 years since I started my journey in cognitive neuroscience laboratory at the Central Institute of Psychiatry during my post graduation. I would say I'm fascinated for computational psychiatry. I'm using fascination because I'm not an expert in it. You are more expert. You all guys, engineers have more expertise in that. And that fascination is the one which actually brought in a collaboration between myself and the National Institute of Technology, Raipur, especially Bikesh sir, Biomedical Engineering Department. We've had some projects in the past. We are conducting. I'm also a part of some of the projects which are still going on. And my study in this particular area has been supported by DBT and DST India so far. I would have a time layout for my presentation because it's a long presentation for 2 hours. So it's a kind of layout that I've set. It may not follow exactly like that, but the layout is for the 40-45 minutes initially. I will continue the session and then a break of 10 minutes maybe in between. The break is because I actually believe in the fact that our attention of human beings doesn't last for long. It's about 20-30 minutes only when we're listening to something continuously. So still, I'm extending that to 40-45 minutes in the initial session, a minutes break after that. Then we resume for another 45 minutes or so. And then I have kept a particular time for discussion so that, there are more and more of questions that I'll be able to answer and more issues that can be risen in that particular program. I start off like this. So, what's a psychiatrist? Why am I speaking to you all? How different am I from other medical professionals? I'm not saying psychiatry is very, the most chosen specialty among medical specialties because commercially it's not the best, but it's definitely distinct. How is it unique or distinct? Because it occupies a unique niche among medical specialties. How is that? Because we psychiatrists are physicians who are best qualified to disentangle the often complex relationship. I will say often complex because in most of the medical disorders, the relationship between biological, psychological, social factors is always there. Be it be any disorder from cancers to depression, the relationship is often very complex in both somatic and mental disorders. And we have got that distinction because we tend to give more time to the patient figure, because we understand that the length of interview depends on how much I am able to know the person, and that well I am able to diagnose that person. So this is a bit of psychiatrist. What is psychiatry? In general, like I've said, we give more time. We still follow, classical books. Carl Jasper's General Psychopathology came in around a century back. We still follow his techniques. The techniques generally, in a small nutshell, is like this. He says pathological symptoms are layered like an onion with outer symptoms. There are outer symptoms which are personality, mood. They are the outermost layer. Then moving inwards to the inner symptoms, like those are called process symptoms like schizophrenia, psychosis, and finally the innermost layer comprising of the organically based, that is brain based. So if someone comes with stroke, for example, that is definitely brain based, right? There is definite say the thrombosis or ischemia in the brain that has led to stroke. But then schizophrenia is little outside. It may be more closer to the brain, but then there is influence of external factors, outer symptoms like personality and mood as well. And if someone has mood disorder, it remains in the outer layer itself. So the deepest layer reached in the course of examination. Important is the course of examination. In a course of interview that we do, the depth of interview that we conduct with the client. That in individual case is very decisive. What initially appears to be a case of hysteria, simply saying that this is hysterical symptoms, may turn out, during the course of examination, you do in a lot of investigations, you examine him thoroughly, once, twice, thrice. Turns out to be multiple sclerosis, suspected neurasthenia, can actually be paralysis, and actually melancholic depression can be actually a symptom of psychosis. So the duration of interview, the depth of interview, determines how deep we are going into the layers and dissecting them. So this is the general process which was taught to us, which was written by Karl Jaspers around a century back, but still we are following that. So what we follow is a mental status examination. What exactly happens during that examination? So a client has an experience. Say he's experiencing low mood, and he should then express that experience to us. If he keeps it to himself, we are not able to, we will not be able to understand. There is a wrong notion that psychiatrists can understand what's going on in someone's mind before they're expressing it out. No, that's absolutely false. Unless someone expresses that out, we will be unable to understand the experience. So the second part is expression of that experience during the interview, during the examination, and the psychiatrist on this side, a psychiatrist or a psychologist, has to understand that expression and thereby the experience. So by understanding the expression, we understand the experience with what is going on in the client's mind. So then all these things together will provide a suitable diagnosis or otherwise. So we say that you don't require any diagnosis or any treatment. So it's just normal process. Say many adolescents come to us, with not able to concentrate. We say, oh, this is normal process of adolescence. There's no diagnosis as such that you'll require, or any other treatment that you'll require. So the process is experience, expression, and we, the professionals on the other side of the chair, has to understand that expression and thereby the experience. So here, not just intelligence, but then the intelligence, I mean in logical intelligence, we also have to understand that what is going on in others' brain. We have to understand that expression. So a lot of social intelligence, our social intelligence quotient should be very high. We have to understand the emotions that are going on in someone's, the client's, how what are the emotions that he's going through. We need to have that emotional intelligence as well. So being on this side of the chair, when someone expresses some experience, needs a lot of intelligence together. And with that intelligence, what do? We have an array of treatments that are there, which we have to choose. So here, more than logical intelligence, we have to have a very tremendous knowledge about the subject. We have to keep updating ourselves. So we decide treatment based on severity of illness, how the course of illness has been. Was it episodic? Did it occur long after a long period, or it has been occurring for a long period of time? Previous response has a previous response been good on some drugs, so I'll start that medication again. Easy susceptible to certain side effects. Someone has comorbidities like diabetes, so what is the medication that I'll have to be choosing? What is the efficacy profile of the drug, of the medication which I have at hand? And then most importantly, it's the client's treatment mindedness. Many of them come to us saying, no, hum dawai nahi khayenge. We are not keen in taking medications. But send us, take us to a talk therapy or a therapy session. I'm not keen in taking medications. Some come saying that we don't want psychotherapy. We just want a pill. Prescribe us some medications, and we are okay. So treatment mindedness is also important. So what are the different drawbacks of this particular method of examination, diagnosing, and treatment? So first, now there is client level. There is stigma, a lot of stigma. People who get referred from medicine department saying that you primarily don't have any pain diagnosis or anything else, but then it's basically depression. So, but they don't turn up to us. They simply go off saying that ये कहाँ मुझे psychiatry भेज दे रहे हैं, मैं पागल नहीं हूँ. These are the things that come to their mind. So there is a lot of hesitancy, stigma. There is varying presentations also. There is no single presentation of depression or schizophrenia. Every patient presents in a different way. Lack of stability, the symptoms keep changing. Today what seems depression later on might change. So client level, there can be stability in the way they express it out to us. Although they might hide some symptoms initially, later on during the course of interview will tell us that, oh, I have been harboring these symptoms previously as well. And psychiatry level, at the level of the specialty itself, there are different schools of thought. There is a biological school which believes that everything is brain. There is, on the opposite, they say everything is mind. There's everything is about thought, personality, etc. So there are different schools of thoughts. We lack reliable markers. We don't have something like blood pressure. If I go saying, say I'm having a headache, please measure my blood pressure. My blood pressure is 160, 110, and I say yes, you have hypertension. That is and you get treat the high blood pressure, your headache goes off. So that is a reliable marker. But then in psychiatry or in neuropsychiatry at large, we don't have very reliable markers like that. We have fixed criteria based diagnosis. We have set of diagnostic uh, systems. ICD and DSM are the ICD are the diagnostic systems we follow. They are very fixed criteria, and also they lack validity. They keep changing year after year, and there's no exact validity to them. At the level of the psychiatrist, often there are 100 patients waiting outside. I don't have the time to conduct that length of interview where I understand, I peel off each layer of the onion. So time and disposal is very important, and something like someone who doesn't have enough patients has enough time, but on the other hand, someone doesn't have much that time. So varying training and knowledge. There are different institutes in India which train in different way, train thoroughly. Some institutes don't have that much of training. They don't have enough teaching faculty with them. So psychiatrists in general will have varying level of training and knowledge, varying intelligence as well, because intelligence is a construct which is not that every psychiatrist will have this much of intelligence, or every cardiologist will have this much of intelligence. No, so there will be varying level of intelligence as well. So when it comes to intelligence, logical intelligence, social intelligence, if someone would have asked me what is artificial intelligence, maybe around say 4 or 5 years back, I would simply say that I know about only one thing about that is Endiran, maybe that robot, how robots work. I would say AI to me around 5 years back was equivalent to robot which doesn't have emotion but can do everything else like humans. So that is the first thing that I must be having around 5 years back. Slowly it changed, changed with my interest in computational psychiatry, my collaboration with engineers like Vikesh sir, and working with them. So later on, I understood what is artificial intelligence. In fact, we did a study wherein we used certain artificial intelligence models, specifically machine learning models, to classify patients of schizophrenia using an EEG. Therein, that this study exactly told me what artificial intelligence is, where machine learning lies inside artificial intelligence, what is deep learning, all these things. And in fact, in my introduction, they said I have got some awards as well. This particular study also received an award. To be honest, I'll tell you, when I presented this study in front of in the national conference, I knew that there are only few who could understand this, because they are also at the same level where artificial intelligence for them is only Rajni. So, and this fetched me award. I would rather say that that award was given to me because they thought everything was beyond their intelligence. That's how it deserves that award. But yeah, this is how it is, because most of we clinicians are not very aware of what artificial intelligence is. But I thought, yeah, I'm intelligent enough. I got this award. In that process, I understood what are the different types of machine learning. We used machine learning for classification purpose. Yeah, I thought I am intelligent, but that is exactly when I thought, why I feel my wife always thinks I am an idiot. This in most of the cases with husbands, our wives always feel, no, yeah, ये तो idiot है. Now, I understood why I'm an idiot, because all that while I'm saying, oh, I'm very intelligent. When Bikesh sir told me that you'll have to take a lecture on intelligent computing, computational intelligence, I just went on to search some literature. Is it the same machine learning that I applied in my study? Is that the only thing which I'm going to tell audience? What am I going to tell for 2 hours? So these are the things that came in my mind. Then when I went through literature, there are different intelligences. I talked about logical intelligence, social intelligence, emotional intelligence. No, all those were only restricted to my knowledge. There are more intelligences as well. Something was machine intelligence, artificial intelligence, computational intelligence. I initially thought they are synonyms for each other, but no, they are completely different is what I got to know. Machine intelligence is an umbrella term. I think there are different definitions as well, but what I thought will be easy for me to understand rather than and easy to explain to you people here is that there's one entity called machine intelligence, and in that there is hard computing and soft computing. Hard computing part is termed as artificial intelligence, whereas a soft computing, which basically adapts itself, it understands what mistakes it is doing and then adapt to it. Those aspects are called as computational intelligence. I went further to understand what are the different techniques, what are the different types of artificial or computational intelligence. This is the figure I got. And on one hand, artificial intelligence, expert system, robotics, machine learning, machine vision, speech recognition, etc., etc. On the other hand, all new terms for me. Something called fuzzy logic. It was fuzzy, initially, but then I went on to read some things about it. Neural networks. I had been, hearing this term neural network for some time, but then didn't know exactly what it is. Again, some other new terms for me, genetic algorithm. All that while I was thinking something related to genetics, but I thought no. I came to know that it is nothing genetics, only a bit of genetics, but it's completely computational. Swarm intelligence, artificial life, evolutionary programming, all these were very new to me. So artificial intelligence is different, computational intelligence is different. Now, the topic that was given to me was intelligent computing. Where does this fall? Initially, I thought it is computational intelligence. I still hope that it is only computational intelligence. I'm still not sure where it falls. But in this presentation, I would mainly focus on computational intelligence aspects and different techniques, but also the conventional artificial intelligence like support vector machines, because I had a work in that, so I'll talk about those things as well. So now I told about these drawbacks in psychiatry examination, understanding, diagnosing, and treating. So can artificial intelligence or computational intelligence solve any of these? So first notion was client level. I cannot change. I cannot change how the other person feels. So what I can change is, when I have uniform system where I can say that with validity, these are the systems that can work. So there can be one school of thought. Like I remember a speaker from US, he headed the National Institute for Mental Health there. He said until Galileo discovered telescope, there were different schools of thoughts. How Earth is, what is the size of the Earth, shape of the Earth, did Earth revolve around sun or sun revolved around Earth. There were different schools of thoughts, but then once Galileo got the telescope, things changed and there was one unit. The number of schools of thought came down. Similarly, that can happen with computational intelligence and its application in psychiatry. Lack of reliable markers and the validity. All this can change if computational intelligence can solve those problems, solve those inherent problems with markers. I will come to each of them later. And then with AI or computational intelligence, I can actually have less time. I don't have to have a I can have a uniform training because computer does everything for me. So at psychiatrist level, there can be significant change. So the drawbacks of psychiatry, AI or computational intelligence, it's assumed that they can solve a few of those problems, and that's why this talk is. But then when I say all these can be changed, then maybe at some level, at client level as well, there can be the hesitancy can reduce. There can be more acceptance towards this kind of assessment. That also is possible. So all these things can artificial intelligence or computational intelligence can solve. So what are the different applications? There are different various applications of AI or computational intelligence in psychiatry, but I will focus on certain things which I think I can tell to you with some certainty. One is diagnostic. So we can use different computational intelligence models for diagnosing certain disorders uh, in a specific way, not that rather than the conventional way that we do. So diagnostic applications can be those that can be used directly in the clinics or those that can be used in laboratory. And then prediction. Prediction is predicting a course of illness, predicting before the onset of illness whether this person can actually have the diagnosis or not. So these are the accepted applications of psychiatry in the current date. So first, clinical diagnosis. So like I've said, onion peel, different layers, and what these actually layers are, how do we do that in daily practice. So if someone presents with depressed mood, I first see enough for how long it has been, then ask him whether there are other accompanying psychotic symptoms like hallucinations or delusions. Then secondly, I see whether what is the course of illness, whether it's a bipolar depression or unipolar depression. Then I ask further questions. I ask him whether there is any medication that he has been taking, whether that has led to this depression, whether he's in alcohol can actually also cause depression, so whether those things are there or not. From then on, I keep asking a lot of other set of questions, whether he has gone through grief recently, is there any premenstrual dysphoric disorder in women with who present with depression. At the end, I kind of come to a conclusion with that, it's a persistent disorder, it's unipolar depression, it's bipolar depression, it's depression with psychosis, etc., etc. All this look like this is an algorithm which looks okay, this is like in a checklist kind of a thing, you can easily do that. But then they are not as discrete as they seem. There's a lot is based on subjectivity of the client, the way he will tell to you, the way he'll disclose certain things, the way he expresses things to me, and also the subjectivity in how I understand that expression, how I'm able to tease certain things out, how I'm able to have that kind of rapport with him that he actually tells a lot of things to me. So there's a lot of subjectivity in the client. So among these computation intelligence models, any of it can solve these hidden layers, which are there underneath, the knowledge, other things which come in, which do not which we cannot quantify them, right? So fuzzy logic is the one. So what fuzzy set or fuzzy logic can do, it can handle non-discrete qualitative inputs. Non-discrete qualitative inputs in this means the kind of knowledge I have, the amount of time investment that I'm able to do there, the kind of analysis that I'm doing with my biases and knowledge within me. So fuzzy logic can actually handle these non-discrete qualitative inputs and analyze like human beings. Use of fuzzy logic in diagnosing psychiatric disorders has been there. So there are many papers that have used this system for diagnosing depression. I'll take depression as a case and explain this further. Then there's something called neural network as well. So there's a new hybrid technique that has been used. Shubhagata, I have found a few papers of him from Berhampur, Odisha, but then he has been working on this for some time, I believe. So the recent, not very recent, 2017. So this particular approach is called the neuro-fuzzy approach. He kind of hybridized. This is a hybrid fuzzy logic and neural network model, and this approach for the diagnosis of depression. I'll go in little detail of this paper because it seems to uh, kind of solve a lot of drawbacks with the conventional interview methods that we do. So first step will be mathematically modeling the manual depression diagnosis process. So we have a process, so how to mathematically model that particular process, understand it, and then mathematically model. Mathematically managing the overlapping grades expressed in terms of mild, we say mild depression, moderate depression, severe depression. So mathematically managing the overlapping grades, then technically handling the large rule base. Rule base means uh, the kind of rules that I have. If it is like this, if these many symptoms are there, I say mild. If these many symptoms are there, I say moderate. So how to technically handle them, and then finally making a crisp final decision based on feed forward back. This is feed forward back propagation is the neural network model that they have been using. BPNN is back propagation neural network. So this they have hybridized with fuzzy logic. So I'll further go into specific. Hello. Yeah. So the process of clinical diagnosing and how to mathematically model the process. This they have actually kind of understood in a crisp. So there are input data, signs and symptoms. then we see the doctor sees it from a clinician eye. There are some intuitions. He kind of matches those patterns with possible diseases which are there in the diagnostic systems. Then he ranks it in a close according to those matches. Then he understands that there are differential diagnosis means there are three kinds of diagnosis that are possible. Then he recommends some investigations, some rating scales, some more assessments by someone. Maybe I refer it to clinical psychologists for diagnostic assessment, and then come back. We give some treatments also initially. uh, so treatments, we see how is the response to treatment, and then finally decide what is the closest match, based on learning experience and all that, come to a final diagnosis. So how is this mathematically modeled and tested? So mathematically they have converted this into an input layer, which are basically the symptoms. Then there are different hidden layers, for this instance hidden layer 1, 2, 3. I'll come to each of it one by one. So input layer 1 is a symptom. So there are different sets of symptoms: feeling sad, insomnia, loss of energy, recurrent thoughts of death, etc., etc. These are the input layers. They were given different codes and they were input. So second layer is a hidden layer, which basically represents the knowledge base, the rule base, and the database that is there. So the first part is fuzzification of the first training case. So fuzzification means, with respect to the different grading system, all these input layers are, brought into this particular model and given, a hidden case to each of it. Then how are these hidden layers mathematically modeled? There's something called this as this, this is a triangular system. Exactly, they call this as a triangular membership function. I think you will be knowing much better about it. Triangular membership function. These three triangles are actually mild, moderate, and severe, and this mu here is the fuzzification correlate. So they kind of match them on this, plot them, and come out with FAs. FAs. Hello. Can everyone be please muted? So FA is a firing area. So they're plotted, and there are these firing areas that are determined. And then the FS here means the firing strength. Based on these firing areas, a final firing strength is determined. And then you'll see this HL1, HL2, HL3. These are hidden layers 1. Then they come out with a final firing strength, and then those bring out an output layer which are tested on the back propagation neural network controller. So it's a hybrid controller using fuzzy logic and neural network, and they bring out the sensitivity specificity of this model with the gold standard diagnosis which the psychiatrist has made. What they have found is they have tremendous sensitivity in diagnosing those grades of depression, but the specificity is almost non-existing. It is 0. But then the predictive validity is quite high, accuracy is quite good, but sensitive means for screening this method is very good. So this is the model that they have used, where there are hidden layers, the rule base, knowledge base, the kind of time which I give. Those they have mathematically modeled as layers and come out with a model which has been found to be quite sensitive. At least for screening, it is good. So apart from fuzzy logic neural network, which I have already spoken, genetic algorithm is another technique that has been used in the past. So what genetic algorithm is, I just went on to understand what it is, how much of genetics is involved in this. But for me, it was a surprise that genetic algorithm for to finding out rules for diagnosing of depression has been there for long. In fact, early 1990s and even before that, there have been there are studies that have used. This is one old such study, and to be honest, I tell you, being interested in biological psychiatry, I know a bit of genetics, but when genetics combines with computational intelligence, it becomes very complex. I heard one of the speaker yesterday saying everything is simple, we make it complicated. I don't know how much they have made it complicated here, I know about genetic algorithm, but it was so difficult for me to comprehend what it is. I'll just tell a bit of it. The type of genetic algorithm that they have used, is a classical algorithm with elitism. The kind of elitism was single best genome preserved. I absolutely don't know what it is. And fitness scaling, and Gaussian mutation was a mutation type. If we understand in deeper, I think we'll have to have more time to understand these things and how we can apply it to it. But then there are more recent studies which have used genetic algorithms to making a diagnosis, using machine learning algorithms. And that's so machine learning as well as genetic algorithms. So what they do, we get input as symptoms, and that input goes into two kinds of it is kind of interacts with two kinds of database. One is the database regarding the symptoms, you know that is there mind data, that is there as database for symptoms. The second is the database for knowledge about expertise from expert psychiatrists about diagnosis of certain disorders. So it kind of interacts with these two databases and comes out using a genetic algorithm, comes out with diagnosis and treatment. So this has been used. The details of it I couldn't understand. I'm really sorry, but then I think with time we'll understand. We should actually go into details. Maybe someone who has worked in this can tell me after my session is over. So there are these different kinds of methods that we can use for clinically diagnosing psychiatric disorders. But then there is this book, a very, very, very nice read. It's called Reading Our Minds by Daniel Barron. So he says psychiatry. He's a psychiatrist. He says psychiatry is still stuck in Freud's era. Like I've said, we still follow, Karl Jasper, Freud. So psychiatry is still stuck in Freud's era. Big data can revolutionize how we care for patients. How can it do? So I'll read out this phrase from his book. He says, when I speak with them means the clients, I want to know what their life is like, what's their day like, what's on their mind, how social are they, how's their sleep. So these are the kinds of questions that I put to clients. Same with me as well. Me as a psychiatrist also puts these questions to them. So these data depend on my patient's ability to remember, accurately report, make sense of, and tell me about their experience exactly. Because they have to understand what is going on through them and then express that experience to me. And further, my treatments depend on my ability to listen and to make sense of what I am hearing exactly, like what I've told about experience, expression, and we understanding that expression. Now, what is the new thing? So if we can record, so recording and analyzing a conversation. So if we can kind of record that conversation, that might help us detect subtle changes in the way people string ideas together. So how they're putting their memories into thoughts and their thoughts into speech, or refer to themselves, the way they string these ideas together to referring to themselves. With use of technology, like say technology here means computational intelligence, subtle changes can be picked up that might remain invisible even to a skilled clinician. So even if a clinician is very skilled, they can remain invisible. Those are the things that the technology can pick up. Such patients previously in a gray zone might have access to more and better treatments, thereby leading to better outcomes. So I completely agree with Daniel Barron. And there are some studies also in this line which actually have seen like that. So they tracked clinical markers through computational analysis of speech. So My Coach Connect is an app, wherein it's a mobile app. They call the conversation happens over call. So call is recorded, the speech is recorded, and then the speech is reviewed, and the assessment has been done by the provider. And then that interacts with two models, the population model and individualized model. And this is where computational intelligence comes into act. And then we kind of understand based on different emotional, connotations which happen during the speech, the acoustic and linguistic features, and then they are correlated with the severity of illness. So this is kind of stuff that also can be done, and we have a precedence here. And there's something called digital phenotyping. This is basically the kind of thing that I've explained just now is called digital phenotyping. So phenotypes are the symptoms that come from them, and we kind of digitalize them. So the field of digital phenotyping has begun somewhere around 2015, not even a decade right now. So from there it has moved on to crowdsourcing. What is crowdsourcing? I tell you. So crowdsourcing is basically having mining data from a big data. So big data mining. Now labeling the data as crowdsourced data. So it's a big data that is available to us. So they have digital phenotypes like eye tracking, etc., etc. Mobile captures, like I've said, recording the speech from them. Then that goes and interacts with the crowdsourced data. Then machine learning, some or any other computational intelligence like fuzzy logic or genetic algorithms. All these can be tested on them. Then that can lead to desktop intervention, the intervention that can be directly given to him at his home. So smartphone interventions or wearable interventions in case of neurodevelopmental disorders like autism. These can be used. So there is a precedence that all this can be done. So these are in use. So in general, there is a network analysis systematic review which came up around 2 years back, which says that in general, this clinical diagnosis and its how computational intelligence can help clinical diagnosis. It suggests that that various aspects of symptoms can, and computational intelligence can improve the centrality of symptoms in a given disorder. So this symptom is for this disorder, this symptom doesn't fall under this disorder. These are the kinds of inputs that it can give, as well as mutual dynamics among symptoms. What is the dynamics among each of these symptoms that can be understood. Now this is a systematic review which tells us that how this analysis can be helpful. Right. So we have understood currently what are the diagnostics in clinical setups that computational intelligence can help us. And I think at this point we can stop and give it a break, and maybe we can have, I can have some questions in the meanwhile also, while others can take break, and we resume after some time. Yeah, I can take up some questions. Are there some participant can post questions in chat box?
Participants can ask questions. Rohit said, yes.
Yes. Have you developed any algorithm for which, like, if we have to distinguish between two cases, like you were explaining bipolar disorder? Similarly, I wanted to know if there is a case of schizophrenia and bipolar disorder. So,
Yeah.
if we have to distinguish from one from another, is there a way that we can do using this approach?
Yeah. Thank you for your question. See, bipolar disorder and schizophrenia. The common thing, why, if classical understanding has been that bipolar disorder is a mood disorder, primarily a disorder of mood, whereas schizophrenia, it's a disorder of thought, or the process thing, which is primary psychosis. There's no core involvement of mood. But then, as we see more and more cases, we find out that common between two is psychosis. Psychosis is there in schizophrenia as well as in bipolar disorder. That is the reason why we need to distinguish, and in many cases, this distinguishing is not very clinically possible. So there are various studies that have been seeing and are able to find out what are the biomarkers that can differentiate this. So there's a big scale study that's going on in US, and there are some centers from India as well as part of it. What they have done is different markers, say electrophysiological markers, neuroimaging markers, cognitive functions that we do on bedside, those markers. They have brought them all together and put them into machine learning, and we're able to see that the distinguishing that we do clinically, whether that is sensitive enough or not, and or see the prediction. If today I'm saying something as bipolar disorder, that will remain bipolar disorder in the later long run or during the course of illness, or it turns out to be schizophrenia. That's called as diagnostic stability. They even have seen the they have predicted the diagnostic stability and have used. So generally this study, which is called as BSNP study, they have been using conventional models only. They have been using conventional support vector models and supervised machine learning models and those things. We specifically haven't worked on those models as yet.
Thank you.
Sir, good morning,
There
sir.
is, yeah.
Yeah, sometimes some people will be talking about some previous information and they'll be relating with something else. Sometimes totally differently they'll be talking. So
Hmm.
how in brain these thought processes will be working?
Yeah. So
Getting
actually,
general.
thank you. Basically, when someone comes to us, when we conduct this interview, there are many generally patients come to us and they express their symptoms very very naturally, and we kind of understand them very easily. But then there are this set of people, who come to us kind of have a varied presentation. I mean, the kind of history of symptoms they come with, they are varied, and when we interview them, they kind of give irrelevant answers. They don't kind of stick to the questions that they have been put up. So uh, we analyze the speech, as irrelevant speech or incoherent speech and all that. We have certain you know uh, certain types of assessments in psychopathology of speech, so we do that. But then what speech analysis, computational analysis of speech can do is, it can also see the law, I mean, linguistics. It can see the acoustics of the speech that comes in, and those kind of things also can give us, those kinds of inputs also can help us in overall understanding what that speech is. So in general, irrelevant speech, incoherent speech kind of gives us an indication that this is primary psychosis. Sometimes we feel that person is hesitant. He's not very keen in telling it to the psychiatrist in front, and that's why he's anxious maybe, and that's why he's not able to put up. So these things we clinically also do, but then computational technique can help us further in understanding how the acoustics of it and how do they change with respect to the kind of diagnosis they present, the kind of diagnosis and the speech presentations they present to us.
Sir,
I hope I
yes, sir. But sometimes doctors will be suggesting for electric shocks and all. What can be the reason for that, sir?
see electric shocks. I mean, this again, this is a stigma that is carried in society in general. So that these are not really electric shocks, that we call it as electroconvulsive therapy. So what has been seen over time is, seizures, epilepsy or seizures can actually, improve certain symptoms. There are certain, only very very few indications they are there wherein electroconvulsive therapy is given in conventional treatment, in classical treatment. Those are suicidal ideations and very severe depression, where someone is not taking food and just wants to, just give his life off. So very severe depression, suicidal, and high, too much, too many hallucinations and delusions which we are unable to handle with antipsychotic drugs or other conventional modes. So these are very few indications. And I'll tell you, electroconvulsive therapy currently is not, they will not even understand that it is a shock. So it's completely done under general anesthesia. General anesthesia, like any other major surgery. So general anesthesia is given, and then these currents are passed. I would still not say it's a shock, because when shock happens, then there are, if it is electric shock, we kind of touch a wire and we fall. We say we got shocked. That is not the kind of shock that happens there. There are particular areas in the brain that through which electric current passes, and that leads to a clinical seizure. So clinical seizure during general anesthesia is not often visually available to us, but then on EEG waves, those epileptic activity will be seen. So we induce seizures through passing electric current, and that helps in treatment. So that is how it is. And there are very clear indications, like I've said, severe suicidal ideations. If someone is clearly suicidal, he can jump anytime, hang himself anytime. A very severe depression where he is not at all taking food, and then treatment resistant hallucinations and delusions where he's hitting others and all that because of delusions, and we are not able to handle them with medication. That is when we choose electroconvulsive therapy.
Sir, is it hereditary, sir, or which component is making this to happen? If it is like from a
Yeah.
particular family background,
Yes. So
is there any?
there is Yeah, there is
Is it?
definite familial influence on the presentation of or onset of psychiatric disorders as well. So, and specifically psychotic disorders and severe mental disorders like bipolar disorder, they have a significant familial predisposition. If you ask me, are there any disorders that have familial disposition and some do not? I would say bipolar disorder, psychosis are the ones which definitely have familial predisposition. But then the disposition or the predisposition varies with family to family. In someone, say if I have one parent with bipolar disorder, the chances of me having maybe are around 20%. If my both parents have got bipolar disorder, or my parents and my grandparents also have bipolar disorder, the chances of me having a bipolar disorder are further higher. So this, when I say they are higher, this is compared to the normal population where someone is not carrying family predisposition. Not that if someone doesn't have a family disposition, he may not have bipolar disorder, he can also have, but then the chances will be much higher in someone having family history of bipolar disorder or psychosis. And generally neurotic disorders like anxiety and them, there is family disposition but not as high as psychosis.
Thank you, sir. Thank you.
Yeah, thank you. There are some questions here.
Rajeshwari, you can ask questions.
Yeah, thank you, ma'am. Sir, you have spoken about some of your patients' history. So, have you ever seen any age group where you can find some similarities and tell that early diagnosis can be recommended for some patient group
Yes.
or later of the time stage when it is really critical?
Yeah, absolutely pertinent. Why we are into biomarkers, why we are doing a lot of computational intelligence is ultimately to see and help patients before they actually have any psychiatric illness. Say why this is important, because with psychiatry as a profession, and especially with treatments around for some time now, it's been around 50-60 years that we have very good medications, but then overall the response of treatment lies to around 50-60% only. There are still that 30% of cases who will not respond completely to these medications or other modes of treatment. So why is it important to stop them before they actually flourish? So that is called as early intervention for us. And the research right now in psychiatry has a lot of focus on early intervention, early detection of cases. So like say, especially with severe mental illness, the other less severe mental illness can be managed, but with respect to severe mental illness, like you've said, yes, there is a definite age group. That age group is 15 to 24 for me. That is a youth. In census of India, there is a separate category called youth, that is late adolescence, that is 15 to 18, and early adulthood, that is 18 to 24. So 15 to 24 is the age group where the onset of psychosis is more likely. And if we kind of assess these patients, these clients can be first degree relatives, like the previous question. If they are having a familial predisposition, if a kid of 18 years has got both parents bipolar disorder, then we know that he has got high likelihood of having a disorder. So why don't we assess him directly and see whether he has some symptoms, onset of some certain subtle symptoms that we can identify, and stop it there itself. So this is the age group where we can find out from either first degree relatives of patients who have had disorder, or in general population. In general population, the number will be very less, but then these are the strategies that we are going to use. And there are early intervention clinics and early detection clinics elsewhere. In Australia is a very important, very very big center. They have got beautiful research abilities with respect to detecting early and treating them early. Europe has started its own clinics. US has started its own clinic. We also are in a process. In fact, I have a project right now which is looking into these high risk populations, in general population. Go and screen them there in this age group, and try to figure out if there are someone who we can actually give some interventions and stop the illness to flourish. So this is definitely there. And computational intelligence, I'll tell you, will have tremendous impact. In fact, I'll come to these things in my further the second half of my presentation.
Okay, so early adulthood would be
Yes.
late stage, and before that, it would be like we can do some kind of
Yes, yes.
diagnosis.
Yes, 15 to 24 is the age group where
Uh,
we can certainly, there are different constructs. Basically, we say arms,
okay,
ARM. So these are called as at-risk mental states. So
okay,
there are some subtle behavioral changes, some motoric presentation, some speech abnormalities, some different difficulties in concentrations and all these things. So different, very specific kind of concentrational, attentional problems. So when we combine this, saying that no, he already has a familial predisposition and started having these symptoms, then we should intervene there itself. So there are interventions, mostly psychotherapeutic interventions, because starting a drug is not very ethical in those cases. But then there are other interventions where we can easily stop the illness to flourish, or have the onset in full blown onset.
okay. Thanks a lot, sir. Your slides are very informative. Thank you.
Can we go ahead, or are there any other questions?
Sir, please start. We can take questions in last also.
Yeah, we can definitely take questions later on. Yeah, thanks. Thank you all. Yeah, we'll start off the second part of my presentation. Basically, so far we have understood that in clinics also, when we are having to diagnose psychiatric disorders, AI or computational intelligence and their techniques can be helpful. So we'll come to the lab part of it. So I was answering a few questions in the break. Uh, Biomarkers. What are different biomarkers? So on the left, you can see that biomarkers can be of different types. So what we are what we are really interested is a diagnostic biomarker which is available to us in the clinic, or we send an investigation to the lab and they give out. Say we say, I want to know whether someone has diabetes or not. What do you do? I I ask them to get fasting blood sugar and postprandial blood sugar. So they pick up blood, they send it to the lab, and we have the result in around 2 hours. We understand that yes, fasting blood sugars are high, and this person has got diabetes mellitus. So this is the kind of biomarkers that are available for other medical disorders, but not for psychiatry. So this is one diagnostic biomarker that we are very much interested in. There are other biomarkers as well, like pharmacodynamic response biomarkers, predictive biomarkers, and all that. So I will strict restrict to the diagnostic biomarkers initially, and also to the central biomarkers. So there are peripheral biomarkers like blood, CSF, all that we take and then send it to biochemical investigations. There are other inflammatory markers, so many of inflammatory markers that can be used. But I will restrict myself to the central biomarkers because this is where there is a lot of engineering background that is required. Again, I'm not going into postmortem brain research because nowadays that's not very useful. It's understood. And functional neuroimaging, I think there is one session on medical imaging and their uh, assessment and how computational intelligence models in understanding neuroimages also. So artificial intelligence, this is a very recent paper in Lancet for us in medical is got the one of the highest impact journals, and everyone wants to have papers in Lancet. So artificial intelligence in medical imaging, switching from radiographical pathological data to clinically meaningful endpoints. So again, they are focusing on clinically meaningful endpoints, and there's a lot of computational intelligence models that are being used in functional neuroimaging. Functional neuroimaging means functional MRI, that is magnetic resonance imaging, PET markers, and all those. So I'll not also go into details of it because I think there's one full session on medical imaging and its processing. What I am interested, or many of you will be interested, is electroencephalography. In fact, I was, I think there is one more session which is after this, which is on how to pre-process EEG and all that. So EEG has been of my interest as well, because I believe EEG is one cost-effective method which we can understand the brain dynamics better. An fMRI will cost me around 6,000 per scan. EEG will cost me just 200 rupees. So it's a cost effective. Plus, we can have something called as temporal relationship. A temporal. I mean, when we say what kind of activity that is happening in the brain and how fast we can, collect that information directly. So that kind of temporality of almost 0 seconds temporality, EEG will be able to give me, not other functional neuroimaging methods. So in general, how do we diagnose EEG based biomarkers, or have been using brain EEG based biomarkers? Are we kind of divide the brain activity, EEG activity, in different bands. The bands are delta, theta, alpha, beta, gamma. These are the bands that we divide them into. Okay, and then how do we collect EEG data? Either we collect spontaneous EEG data, which is resting state. You ask the person to close his eyes or open his eyes and simply collect data, not do much. Okay, second is, when we give them some stimulus. That stimulus can be auditory stimulus, a visual stimulus, so, or an event. Say we can give them some mathematical calculations, or we can give some memory based tasks. So it is task related oscillations. So those are called as event related oscillations, or evoked, or otherwise called a steady state. We give auditory or visual stimulus at a particular frequency, and then see what is the response to those steady state. Steady state means, say we give maybe 3 hertz visual photic stimulation, and then see what is the response of brain or EEG to that. So those are the different kinds of EEG data that we collect. And what are the variables that become, or the outcome, EEG outcome variable that we are interested in? Classically, the systems theory methods are used. So power spectral density, the evoked spectra, even event related spectra. In the event related oscillations, we see phase locking, phase synchrony, cross correlation, cross spectrum, EEG coherence, or power spectral coherence, then evoked coherence, event related coherence. These are the generally conventionally used EEG biomarkers with respect to neuropsychiatric disorders. And there are different patterns that have been found, that we have found when assessing these EEG biomarkers in different disorders. I have been interested in EEG biomarkers, and specifically in schizophrenia, seeing how gamma power is between schizophrenia and healthy patients. So my interest basically, my work in cognitive neuroscience started with the study of EEG and its techniques also. We also studied different evoked response potentials like N300, P300, N400, CNV, these markers, and see how we can predict chronicity in alcohol use disorders as well. So there, in evoked response potential studies, we just saw amplitude and latencies. Power spectrum in spontaneous EEG, and evoked response we saw amplitude and latency. And then slowly with time, my interest went on. There are some more few softwares that our institute acquired. So we did functional connectivity, we did S-Loretta, we understood what is source localization, what is localized source current densities, and all those also we worked on. But then there are some problems. There are some inherent problems with these EEG based biomarkers. What are those biomarkers? Because the field of psychiatry has got a lot of inputs from EEG, and not just in last decade or so, but for some time. So what are the different problems with the findings of conventional EEG based biomarkers? They lack reproducibility. If I do it right now on a patient, and see this method is useful, and if some other person, some other laboratory does the same thing, the kind of results he will get will not be exactly the same as us, that's for sure. But then not exactly same, but there is possibility that the results can be entirely different. I get low power, that person can get high power. So that kind of reproducibility is lacking. We lack specificity. Specificity means the findings that I get for schizophrenia may not be specific for schizophrenia. They can be there in bipolar disorder, they can be there in depression, they can be there in any other psychiatric disorder or neurological disorder as well. There's large intra-person variability. Intra-person variability means I do an EEG at 9 a.m. and analyze the data. I do an EEG in the same person at around 3 o'clock and analyze the data. I find different findings. So that kind of large intra-person variability. I do it today, it will be different to tomorrow. If someone is hungry and if someone is not, even if he is in full stomach, the findings will be different. So there is large intraperson variability in EEG findings. Poor clinical translation. So far, there has been a lot of research. Now for me, it's been around 12, 13 years, having my first finding on EEG. Until that, I'm sure, not now, maybe up to 10, 20 years later, I'll not be able to use those biomarkers in my clinic. When I'm doing clinical assessment, it's still completely interview based. I'm not asking them to get EEG and I see the EEG and see, oh, you have schizophrenia, you have depression. No, that's not happened. So there's poor clinical translation so far. And these are the things, this something called Sapien Labs. I'm not very sure whether you all be well versed with. There's this person called as Tara Tyagarajan, who actually has this is in US. She kind of had this Sapien Labs, and now she tells about a lot of pitfalls. She has published a lot of papers as well, which actually talk about these pitfalls, and they also give some suggestions on how to improve this. This research. So first is they say from frequency bands we can go to more integrated views. So that can be one way forward. We'll have to look beyond the spectrum. Power spectrum is a commonest thing that every one of us will be working, but we don't know whether that is clinically translatable. Like I've said, so far we haven't been able to clinically translate that. So this study which I was talking about, which myself in collaboration with NIT Raipur Vikesh sir and Pandit Ravi Shankar Shukla University, the electronics and photonics department, we worked on. Earlier I had acquired some data on EEG, high resolution EEG. We use support vector machine study and see whether that can improve. So this is going beyond power spectrum and seeing other variables as well. So the classical training phase and testing phase was done. So what are the different features that we selected? Now for me, it was something different, right? When I'm saying 12 statistical feature for one, say mean, kurtosis, skewness, all those values, with power. So crest factor, form factor, all this were combined along with power, and then they were extracted for each band. So they resulted in 480. So we had some regions of interest. They resulted in 480 features, where in earlier of my studies I was working on say 6-8 features. Now that we look beyond the how artificial intelligence models, machine learning models have helped me, is that to increase that features to 480. So that is one advantage that I had understood that these kind of techniques will have. And ultimately when we try to compare the activity of these extracted features through support vector machine models, we got fairly good accuracy with respect to classifying someone as schizophrenia or not. And we further used some experiments. We saw whether inside schizophrenia there are different heterogeneous populations. Like someone will have high positive symptom like delusion, hallucination. Someone will have negative symptoms. They'll not talk to you. They'll not eat. They'll sit at one point. They'll not interact with people. So we also saw that the accuracy. In fact, it has got higher accuracy for that. So our techniques, this EEG and use of support vector, could classify the positive symptoms for negative symptoms much with higher accuracy. This is the finding that we got. Again, there are inherent problems with this. The sample size was smaller. Now, problem with smaller sample size is that we need higher sample sizes. Like I've said, there is high intra-person accuracy. So we need long data that should be taken from each candidate, and we should have large samples to see this. Then now coming to the classical computational intelligence, I have found some studies which have used swarm intelligence. Again, like I've said, swarm intelligence for me was a very, very new word. Similar kind of extraction that we did for features that they have done. But then after pre-processing, various features were extracted. What are the different methods that they've used? Like we use support vector machine. What are the features this particular study used? Where something like AF, artificial flora, GS was glowworm swarm, BH was black hole, MS was monkey search. And I tried to understand what these techniques are, but honestly, I couldn't understand. I couldn't understand to that extent that I can explain you guys. So I'm stopping it here. And these are different kinds of optimization. So I think there is a whole lecture on optimization and techniques. So maybe you can understand these techniques more there. So these also have been used to classify signal classification in schizophrenia, or definitely it can be used for other psychiatric disorders as well. Like I've said, small samples, all these studies will have small samples. What can happen beyond that is the call for data sharing. We need to share data so that someone at some space, some global space, some cloud space, all the data gets accumulated and someone can work on big data. And then the analytics that we are doing should be shared to them. What is the exact kind of analysis, what are the programs that you have prepared, that also should be available to others, so that a uniform kind of analysis can be done on a very big data. Okay, so search for biomarkers requires a big data approach that explores symptom clusters and EEG metrics across a large number of disorders and subjects, not just large number of subjects, but also large number of disorders, and to see how different each are with respect to these EEG frequency bands. And clearly the metadata means what is the circumstance at which the patient has been taken, pre-lunch, post-lunch, what time of the day, what is he thinking exactly at that point, is he hallucinating at that point, is he very low at that point, is he harboring suicidal thoughts at that point. And so that state of mind at the time of recording also should be mentioned in this when we are sharing data. So NIT with Vikesh sir is one more study. Basically Soumya is a PhD student there, who she actually got this data from the data sharing thing. So she acquired that data from already existing data which is there in the cloud. She did some analysis called empirical mode decomposition, again a machine learning approach, to see these resting state analysis. So what I mean to say is, when we share data which is available to others, they can use their approaches and see how that is working on this particular data set, compare that with the data set that they have acquired before. So all these things are possible, and more importantly, if 100 people share the data of 10 subjects each, we'll have 1,000 subjects together. So, and then we have different kinds of analysis methods. One of that analysis method, which is the most useful, can be used on the whole 1,000 data set. So that is the advantage, and that's how the EEG biomarkers will flourish and will be helpful for translation in clinical practice. So next, in that, beyond that, use clinical as well as lab diagnosis. We have clinical diagnostic methods. Now we have lab diagnostic methods like EEG. Clinical, I meant speech, analyze speech. So this is again Bikesh sir's project. We have got that prestigious DST Cognitive Science Research Initiative fellowship for this, where we are trying to develop a multimodal artificial intelligence system for schizophrenia and its endophenotypes, where we are studying schizophrenia subjects, their first degree relatives who have not had schizophrenia so far, and seeing them what is the the composite biomarker, like automated speech analysis plus EEG, how does it help. So this is another study that we are conducting. So there are similar studies in the past, but we can have our own data once we finish this data. So point is, we can combine clinical, which can be speech observations, behavioral observations, all those things, plus lab features like EEG, maybe fMRI, some other biochemical tests. We can combine all these biomarkers together and run them through a lot of artificial intelligence or computational intelligence models. Like I've said, apart from the diagnostic markers, we have risk markers, monitoring biomarkers. We can predict the response of a particular treatment and how this biomarker can be helpful in that particular paradigm. And then safety biomarkers, how a biomarker indicates the safety profile of the particular medication or an intervention. Those things can also be done. So now we have covered with respect to the applications of MI, the machine intelligence, the computational intelligence, the diagnostics in clinics, now the lab. Now, like I've said, there are predictive biomarkers also. I put it separately, I've not put them as biomarkers. So prediction or prognostic markers. Now, what are they? So there are many predictions that can be done in psychiatry, like even in the question that I tried to answer in the break, the onset of illness in high risk individuals. So other predictions that are very important are predicting dementia in subjects who have aged, predicting suicide in subjects who already had some suicide ideation or depressive features. Then predicting treatment response. If I have given it one particular drug medication, whether that will suit him, whether that will predict response or it will predict a failure. So that kind of predictions can be done, and there are studies which have used computation intelligence models to do that, to basically improve the kind of prediction. So first coming to the dementia or MCA is mild cognitive impairment. Mild cognitive impairment is a stage where they are not dementia, but they have some cognitive impairment which is more than age appropriate. Now, so for example, we expect any person who is 70-year-old to have some memory problems. So this MCA, mild cognitive impairment, is higher than that, but not amounting to a diagnosis of dementia. So this is a paper in BMJ's British Medical Journal, Journal of Psychiatry, again a very prestigious journal. So what they have found is, that there are several biomarkers for diagnosis of Alzheimer's, dementia, dementia with Lewy body, frontotemporal dementia, vascular dementia. There are different types of dementias, and quite good number of biomarkers are available. So, and what they say is that neuroimaging, especially amyloid PET, amyloid is the marker that is used for PET imaging, has become more accurate and practical in clinical settings and signify a major shift in diagnosing dementia pathology. Dementia, this is for certain. Dementia by far is the only neuropsychiatric disorder where biomarkers have been truly translatable in clinical settings. So if a person with mild cognitive impairment comes to me and says, I have to know whether I will progress to dementia or not, or someone with the age of around 80 years comes to me and say that, I'm having some memory problems, is it dementia? So I do a lot of cognitive assessments for sure. But then at this particular point, even today, I can ask him to get a PET with amyloid PET and see what is the image like, what is the report like. So in this particular point, I can, seeing that report of PET, I can say that that person has a chance of going into prediction into dementia or not. So it is still, it is even now, it is, has got that translatable value. So dementia is the only disorder where this clinical translation has happened. But that can be possible in some cases, but not in all cases. So in certain cases, for sure, the computation intelligence can help. So there are different disorders where this is helpful. Excuse me, just hold for a moment because the charge on my laptop is little low. Excuse me for a moment. Yeah, I'm sorry for the pause. Just a moment. The various computation intelligence models can in fact improve my understanding of biomarkers even in dementia, which I've said it is possible to use them in my bedside clinics. So something called ensemble learning, regression tree, convolutional neural networks, support vector machine learning. This has been there for some time now. Also there are something called as naive Bayes, random forest, deep learning, something called extreme gradient boosting. I'm not sure about these techniques, what exactly they are, but then machine learning and novel biomarkers can actually improve the translatability of these biomarkers in my clinic. So this is a very new review that has come up, which says this. Now there's something more to it. So not just these biomarkers. When people say that apart from these standard neuropsychological battery tests or neuroimaging, what we can do is something called as gait kinematics. This is a very interesting paper that I found. Now this person who with 70 years who comes to me, I kind of allow them to go into this chamber, which is called as cave, literally, and wherein they are allowed to do household chores, some activities of daily living which require some performance, like say for example knitting, or a simple task like this, grooming her hair or something. So I ask them, and there are different projectors and cameras which actually see the activities and what are the different gait kinematics during that particular activity, and then that is taken along with the other standard neuropsychological battery and put into machine learning, and then there are predictive models that are run then, and then give a dimensional MCA diagnosis on that continuum, where in that continuum of age, mild cognitive impairment and dementia that they lie. So this is a kind of uh, that novelty that that computational intelligence is bringing to us, and will definitely be helpful in understanding what these patients are, at what stage they are, and starting their treatments. So again, psychosis in high risk, like I've said, is my interest area. I mean, for sure, why are we working on biomarkers is because to stop someone from having complete onset of psychosis, even before that, identify them and start treating them. So MI, machine intelligence, artificial intelligence, or computational intelligence have got a tremendous role in doing this, because the clinical methods that we use in identifying this high risk population is that those have got their own inherent limitations. So what are the different models that have been used so far? Mostly they have been SVM models, that is support vector machine models only. The novel computational approach models are less used, but then that's why there is a scope for them to use. And and so there are different models. Among different models, again, like I've said, composite models where you use biochemical markers, EEG biomarkers, functional neuroimaging biomarkers, and then put all of them through computational intelligence models. So that's very good. Now, predicting suicide. This is another important thing as a psychiatrist, which or as medical professionals, we are very unsure of. We say that someone is suicidal, he is harboring suicidal thoughts, but whether or not that person will end up committing suicide or dying by suicide is a very, I mean, it's very difficult to predict that. But then there is an approach called like I've said, backpropagation neural network is one entity that is used in neural network. So that has been used to create a suicide risk assessment scale. Now this is called as computerized suicide risk scale, which is used backpropagation neural network, and has seen that by actually reviewing a lot of records, just reviewing the medical records of that, it's possible to predict who is going to have suicidal ideation, or who can go and commit suicide. So this is the kind of prediction that this suicide risk assessment scale can do. Of late, again, like I've said, hybrid fuzzy logic and neural network. So this is something called as Falcon, which is fuzzy adaptive learning control neural network. So this is another hybrid technique which they have used, both fuzzy logic and neural network, to predict suicide using the CSRS, that is computerized suicide risk scale. So this is also in use. It kind of increases my armory, in which where I'm using my clinical skills as well as this data to predict someone, whether that how much risk someone has to commit, in committing suicide, or having next suicide attempt. Now, predicting treatment response, there are different algorithms which say that whether if I'm saying, say for example, if I'm giving an antidepressant to one person and want to see how he responds, there is chances 50% chances he will definitely respond, or 50% chance there is a likelihood that he'll come back to me and say it's not responding. I either increase the dose or change the antidepressant itself. So are there any machine learning algorithm that can help me predict that response and choose the right drug straight away at the first point? So machine learning algorithms have been useful in doing this. Like here you see TCA is one kind of antidepressant which is called as tricyclic antidepressant. SSRI here you see is that is selective serotonin reuptake inhibitor, that is another kind of antidepressant. Antipsychotic usage also has been seen in antidepressants. So these are different kinds of different treatments, and these are the predictors which have been found based on machine learning algorithms. So attention, cardiac symptoms, and that those respond to antipsychotics well. And if the duration of illness is higher, there are vegetative symptoms, they respond to SSRI as well. Someone has a higher duration of episode, openness, more affective symptoms, neuroticism, they are likely to respond to TCS more. So this is a kind of output that I get when I combine a lot of machine learning algorithms in predicting antidepressant response. So there are some newer studies which have shown that deep learning also has been used to predict such models, predict such responses. Now, when I say I am predicting, beforehand what this person might have, whether he'll respond to this drug well or not, whether he'll have suicidal ideation in the future course or not, like these things. So this is exactly what precision psychiatry means. This is all a few new field of precision psychiatry, which says there are a lot of biomarkers in our surroundings which we can definitely do it, not really at our clinics, but then we can send them to different centers and get inputs on this. And what is core to the precision psychiatry is computational psychiatry. So we need biosignatures of it, and computational intelligence has got significant role in helping us, to enhance this field of precision psychiatry, wherein I will know how different a treatment or a presentation in one person will be when compared to the other person who is next in line. So that is exactly what is precision psychiatry. And again, there's a new field of computational psychiatry, not just a field of computational psychiatry. I found out that there's a new journal called as computational psychiatry, in total. So what they say, this is again Cell Press, very reputed journal, wherein different aspects of computational psychiatry have been told, like data mining, like I've said, biophysical modeling, then computational modeling, computational phenotyping, or digital signatures, digital phenotyping, which I've told earlier. So they can all together identify new genetic, molecular, cellular, and neural dynamics of psychiatric disorders, enable large-scale data sharing, explore biomarkers for healthy and damaged cognition. So we'll have to know what is healthy, what is unhealthy, so what is psychiatrically healthy, what is psychiatrically unhealthy. Provide computational assessments of therapies as well, not just for diagnosing, but then when you're doing certain treatments, like I've said, and when predicting treatment response. So we should have computational assessments of therapies as well. This is in general what is precision psychiatry, how computational intelligence can help precision psychiatry and bring out the whole new field of computational psychiatry. So we have understood clinics, how machine intelligence can be helpful in diagnosing in clinics with respect to how we interview. Then we have different lab parameters and how those lab parameters can be put into machine learning or computational intelligence paradigms and get more inputs from them. Then also about predicting someone, whether someone will have dementia or not, whether someone in high risk in that youth age group will have psychosis onset or not, someone who has had depressive symptoms will have future suicidal attempts or not, or if someone who is started on any antidepressant or any other anti-psychotic drug, any psychotropic drug, how well he will respond to that treatment. So there are prediction prognostic markers in a new field of computational psychiatry. All those we have covered so far. So any others you'll ask me, any other that can happen. I don't know whether this is suitable for now or not. It's only, a presumption. There's something called a concept of smart cities, and there people have seen that machine learning approaches will in fact enhance the smart healthcare of those smart cities. How the services are utilized, how well the healthcare is put in line, how they are lined up or not, those things, whether they can do or not. Then second is, particularly swarm intelligence model has been seen for enhancing healthcare services, in these smart cities. So that kind of intelligence models, which I've told you in my previous slides, those can in fact enhance the whole healthcare services. Say for example, you want how many hospitals to be there, how many psychiatrists to be there, how many psychologists to be there, how many beds in each hospital to be there, whether there is a demand or not, what is the need. Those things, swarm intelligence models can actually help. And in the end, a question comes to all of us, like, can computational intelligence replace human intelligence, specifically in the context of psychiatry? To me, when you ask me like this, or I would rather put this question to you, audience, whether with this presentation you think that computational intelligence can replace human intelligence, because I've told you how we actually diagnose and treat in the initial part, classically, conventionally in my clinics, and how computational intelligence can help. So with this, can computational intelligence replace human intelligence or not? So if you ask me, I am not sure. I can say, okay, maybe 70% not, 30% yes. Now, with this question, some people have also conducted some global surveys wherein psychiatrists have been asked, exactly this question. So very less number of psychiatrists, 6.7%, they say it will not influence, computation intelligence will not influence the way they are working right now diagnosing. Someone said there can be minimal influences. Most of them said there will be moderate influence. So jobs will change substantially. Jobs changing means I will get a lot of help. Maybe I'll have to spend less time on the patient. I will be able to see more patients in that time. So that kind of influence it might have. And very less number again said it is going to have extreme influence. This is a kind of response that these people have got. But then this is from psychiatrist's point of view. I want to know also, what is your point of view on this. And with this, I'll end my session and open the session for discussion.
Okay, so questions
Yes,
are welcome from the participants.
I think I'm well in time. I don't know whether I've got through my slides very fast, but still we have
No,
good
no,
enough
sir.
time. Good
Yes,
enough
sir.
time for discussion. Yes.
Harjeet Singh, you have posted some questions in your chat box.
Priyanka, you can read it if possible.
Yes, sir. Yes, sir. Sir, can you suggest any techniques to find out depression level among family members?
No, I'm not sure of what exactly the question is. Like, you want to know if someone is depressed. You want to know in family members what is the level of depression.
What is the level of depression they want to know? Any technique to measure that or to find out?
Like I've said, there should be an input. So the input basically is the presentation that the person will give. Unless we know, some kind of input, like say how sad they're feeling, or some questions like that. Until we give that input, it's very difficult. We'll have to interview those family members as well. I mean, there's no way that without knowing what is going on in them, we can identify how much level of depression will be there in them. We can maybe say how much risk they are at if someone has, in the family has depression. So what is the amount of risk the other persons will have to have depression in the future? That risk we can definitely predict. But currently, how much depression they have, I don't think. I don't know whether I've got the question right.
No, sir, it's clear. Thank you, sir. Sir, there's another question that they want to elaborate human intelligence.
Mm-hmm.
Ranjit Dhunde.
Elaborate
Say,
human intelligence.
human intelligence. Yes, sir.
Yes. So, say there are two ways generally. Grossly, there are two ways in which we look at intelligence. One is qualitative way. We say something is very rigid. It will remain. That's called as crystallized intelligence. Crystallized intelligence is like we acquire during our developmental phase, and it crystallizes at around 18 years. By around 15, 18 years, it around crystallizes. That is that it whatever you have acquired till then will remain like that. Next is fluid intelligence. Fluid intelligence is the one which I have. If I read a new book, I kind of gather some intelligence. Maybe I gather 40%, you may be gathering 50%. So it remains fluid. You kind of learn new things, unlearn new things, forget some things. So this is fluid intelligence. So grossly, this is it. But then when you see quantitatively, further divide intelligence into different parts. Most of it is logical intelligence. When we say intelligence or IQ, it's logical intelligence. So the other part is social or emotional intelligence. So how we can understand others' emotions, how we can understand others' actions, social actions. If someone does namaste, we should salute him or do namaste. That is what is social intelligence. So, and then now coming to the logical intelligence itself, there are two. In that we divide very quantitatively. When we say IQ of someone has IQ of 100, that means that 100 is divided into parts. So that can be performance anxiety. Performance intelligence. So performance intelligence is if they're doing they are given some tasks to do, how do they perform motorically? So that is performance. The other one is called written, or that is verbal intelligence. So how they answer, it's like oral versus written. Written is performance, whereas oral examination is your verbal intelligence. Then again, there are subdomains of it, mathematics, calculation, different immediate memory, short-term memory, abstract ability. There are different parts of intelligence as well. So this is how we understand intelligence from assessment point of view, and from understanding point of view, it is fluid and crystallized.
Thank you, sir.
Thank you.
Some more questions are there. Please explain. Okay, continue.
So they want to know that is there any data set available for the study?
What study? I mean, there are different data sets. I think there are various websites wherein the data gets pooled. There are different. Maybe if someone gives their email on the chat box, I'll email them all those clouds where each data is there. There are live platforms in which people keep sharing results. The data that is available for others also to do the same analysis and see whether they have got the same results or not. There are different platforms.
Okay, sir. Any more questions, participants?
Sir, with regard to the overlapping symptoms of different psychiatric disorders,
Yes.
you were mentioning that there is a long way to go, and how the psychiatrists are really looking at it, sir, and how do they really try to complement with us?
Yeah. I mean, I'll have to tell you a little bit in detail. I don't know why my voice is echoing. Can you mute yourself? Hello? Yeah, this is fine. So generally when the classification in psychiatry started, it started with a very simple classification. Maybe you will not be aware, there's a name called Emil Kraepelin, and that is Freud's era, Carl Jasper's era. So he simply classified someone as got nervous disorders and mental disorders. In that time, mental disorders generally are called nervous disorders or psychotic disorders. Only simple classification. Then slowly they classified further. So psychotic disorders came into two, mood disorders, then primary psychotic disorders. Then primary psychotic disorders again further classified. Now we are at a point where we have a whole set of diagnoses. The neurotic disorders from anxiety, OCD, that is obsessive compulsive disorder, to a lot of stress related disorders, post-traumatic stress disorders, etc. And psychotic disorders on the other hand, you'll see bipolar disorder, psychotic disorder, schizophrenia, schizoaffective, so many like that. So, and in the meanwhile only, in the 1900s, early 1900s only, there's a person called Carl Menninger. I don't know, he's very, he has written a lot of books on that in other aspects of health psychology as well. So he said there's something called as unitary psychosis, something unitary, everything is one, nothing is different. Everything is just one, they are simply different parts of it, but then we are just seeing it as different, but then they are all same. So now slowly people have started feeling that again there's only probably broad classification of neurotic and psychotic only. All psychotic disorders are similar, like this. Now, but then when it comes to seeing individuals do not know when they present with us with symptoms. They do not know whether they have psychosis, neurosis, what kind of psychosis. They have not read that, but this is symptoms, this they are there. So we need to put them into classifications, different sets, because so that it will help us choose better treatments. That's the basic purpose of classifying. The main purpose of classifying is, if I classify someone as schizophrenia, I'm classifying someone as depression. So in depression, I choose antidepressants. In schizophrenia, I choose antipsychotics, generally. So this is the primary reason for classification. Okay, now how computational intelligence can help me in this? So I can be correct in 80% cases, wrong in 20% cases in such classification. Now computational intelligence will help me in enhancing that accuracy. When I'm 80% correct, with help of computational intelligence or artificial intelligence, I can improve that accuracy to 95%. In 95% of the chance of the cases, I'll be correctly diagnosing someone as psychosis as psychosis. Currently diagnosing someone as depression as depression. So that is how it will help me.
Yes, sir. Yes, sir. Thank you, sir. Because you said after 13 years, still there's a long way to go. And
Absolutely.
because when I interacted with some of the psychiatrists, they were literally stoning me. They said, "You don't come near us. You engineers are trying to, say something," and they were not very receptive.
No,
Probably that
no,
was
yeah,
that was where I was facing challenges when I was talking to some of the psychiatrists.
definitely. I mean, this challenge you'll definitely face, uh, because I know, like I've told, we come with, the kind of psychiatrist you might have met, and the
Yeah,
kind of
yeah.
psychiatrist I am or someone else is.
Yes,
We
sir.
come
Yes,
with
sir.
the
That's
different
true.
backgrounds.
Yeah,
So,
that's true.
it complete. When I said I'm fascinated with computational, intelligence, I'm actually fascinated. That person may not be. I'm very much interested, and hence I have my own ways at looking at it. And I for sure feel that it can definitely help me in enhancing the accuracy.
Thank you, sir. Thank you very much.
Any further questions, participants?
There are so many questions. I just opened my
Sir, please explain. There is one question.
Yes, sir.
Please explain the challenges faced during data collection.
Yeah. Thank you so much for this question. I mean, it's a challenge. So data collection, you mean data collection? There are different types of data collection when we are looking at one study. So I'll talk about my project. So our project, which we are working, wherein we are getting some behavioral data sets as well, and also some EEG or other markers. So first is a interview. Well, what's important for the basic thing is interview. So we need to do interview and then get that input number of symptoms. How sad he is, how what is what is the sleep like, what is the appetite like. That is the first part of interview. So that is first. Second is collecting EEG data. And now the challenge is not in collecting data from so collecting data now. I'll say from healthy, we'll have a healthy comparison group also, who don't have any psychiatric disorder. The easiest, there's no challenge in getting this data from them, right? Except for getting the consent. They will say, why are you doing this assessment to me? Is EEG, most of them actually relate EEG to ECT. Like, the moment I say I will put some wire here, they say, are you not going to give me electric shock? So that is first challenge. Okay, that is, otherwise there's no challenge in collecting data from healthy volunteers. Second is, it's easy to get data from patients with depression, or who come with, patients with depression come with symptoms of depression. More challenging are the psychosis cases. So I have been working on schizophrenia, and I know how difficult it is, because when we collect data, first is we need that amount of time where we give. So basically we divide our time, and I do some rating skills in the morning, I come to him in the evening. But when it comes to EEG or any other neuroimaging technique, I need definitely 1/2 an hour recording. So that getting that 1/2 an hour artifact free is very, very difficult. Yeah, that is where again there is another challenge. We kind of include cooperative patients and not really the general schizophrenia. We kind of leave out people who are not cooperative, but then they are also schizophrenia. They are most likely more schizophrenia than the ones who cooperate with us. So that challenge is there. We need to prompt them, give them positive prompts, and say that this is going to be useful. Try to explain him further, give that informed consent in very detail so that he understands. Not that patient with schizophrenia won't understand these things; they'll definitely understand these things. So the challenge is there. So and once the data is collected, it's after that computers will take over. You engineers will take over.
So one more question is there, that if any disease is diagnosed by clinical data and at some stage, they can recommend image type of data also. So for prediction of that type of disease, which type of data should we prefer for more accuracy? Diseases like CKD, because both type dataset algorithm is also different.
Yeah, CKD means chronic kidney disease, is it?
Yes, sir.
Yeah. So say kidney diseases. So first you see symptoms. Like initially maybe they come with some urinary symptoms. Then there are systemic symptoms wherein there is anemia. There are some puffiness, swelling all over the body. Then there is drop in the hemoglobin slowly. So when do we recommend is, when they have systemic diseases, just systemic manifestations. Okay, when they have systemic manifestations, we think that this is beyond simple urinary tract infection. Every other kidney disease, generally, they at first instance we feel commonest thing is rule out urinary tract infections. So we find, but then when these symptoms are accompanied by systemic symptoms, then we kind of ask for other investigations, right? So similarly in psychiatric disorders, like I said, onion layers and those things. When someone says that I have depressed, now see, we simply ask set of questions that you have this is. We feel okay, only depression. There's no imaging that is required at that particular point of time. Then next, he tells us that more than depression, I have more hallucination. I have started having hallucinations, and some maybe I'm feeling very low. Slowly after time, this one half of my body is not working properly. That is when we have hard neurological signs coming in. Hard neurological signs, like they start having diplopia, simple symptoms like which represent core neurological disease. That is when we actually recommend imaging. It can be CT, MRI, preferably MRI in most cases. That is when we recommend clinically. But then when it comes to research modality, it all depends on the project, the kind of project you are. Like say you want to image someone with only high risk symptoms, you can as well do that. But then in clinics currently, the recommendation is, unless you have a reason to rule out anything neurological, which can be something in the brain, we don't generally recommend any neuroimaging. So you ask, so for prediction of that type of disease, which type of data set should we prefer for more accuracy? So you want more accuracy, definitely a combination of sets. You have clinical data with you, and also you have imaging data with you. You correlate both of them, use that both for prediction analysis, and see, that will definitely be the best. Always composite indices are more useful. In initial part of say someone only presented with depression, at that point, even if I get CT scan, now there are chances that it can show me something. But then say for example, if 100 patients of depression come to me, there is likelihood of only one or even maybe less than 1% chance that they will have some abnormality in the neuroimaging. So I will not go for it. I guess I'm clear.
Okay, sir. Thank you, sir.
Okay, I'll add little bit to this. Miss Pooja, actually, if you talk about intelligent computing, if you want to combine both the data sets, then you can do it at feature level. It means that you can extract features from both the data, that is from the signal as well as from the images. Okay, it means the clinical data as well as the features that are extracted from images, and then you can fuse them at feature level. Means you can fuse the features. When the individual data are completely different, they cannot be fused at data level. So you can fuse it at feature level. You can extract. You have your clinical data, which will be usually either in form of some numbers or values, and then you have image data. So you can extract features from that data, and then you can combine them, and then you can apply it to the algorithm. So in that way, you can combine the data, and then you can check whether combining both improves the performance or the individual performance is better. Like that kind of evaluation also you can do.
Okay, sir. Thank you, sir.
Thank you, Vikesh sir.
Participants, any doubts?
If there are any other questions from the participants, they are welcome. Okay, so I would like to say something that I am one of the collaborators with Sir, and we are doing a lot of work together. We have project also, and we did some more work earlier also before getting a project. And Hardik and Soumya, two of our research students, they are working in this project. It is on schizophrenia, and we have written one more project also related to mental disorders. So, sir is very rare of a person, because when usually when we go to clinicians, there are very few who are so much interested in this computing side. But when I met sir, I found that he has a lot of publications also in this area, computing area, and he is really, as he said, that he is really fascinated and he's really interested in collaborating with these computing techniques and applying it in his interested areas. So those who can reach sir, because there are a lot of participants, if you are lying near sir, like in Hyderabad, or so you can definitely go and meet sometimes sir, and then if you want, you can collaborate. Obviously this data collection collaboration, it is not an easy task. You have to put lot of efforts, lot of time to get collaborations and to collect data and to do this kind of study, because it is a very multidisciplinary kind of study. Not only data collection and analysis, lot of other efforts are also required. Finalizing the research protocol, getting approval of so many authorities like ethical committee and research cell. So a lot of efforts are required, but then once the things are done, and when you actually start doing the study, you will enjoy it. So thank you very much sir for giving your time. I know that the clinicians have no time. They are very busy in the routine clinical work, and also because you all are taking classes also, and at the same time OPDs and other things are there. So I'm extremely thankful to you for giving time to take this lecture.
I should thank you, sir. More than me, I think I should thank you for giving this opportunity. Indeed, a very learning experience, because these are the kinds of academic sessions I look forward to, wherein I get to learn more. Because otherwise, I would not have learned what is the difference between artificial intelligence and computational intelligence ever. And so many new things that I got to know, and I just wanted to give an overview, because I definitely am not an expert in these things, and I just wanted to say how, in what kind of applications that I can have on psychiatry is what I actually intend. And I guess I was
Yes,
able to
yes.
help.
Will
Yes
you
sir, very
share
well.
your mail ID, sir, please?
Mine, I'll put
Yes,
it.
sir.
Yeah.
Okay, so I think with this we can end this session, and thank you very much sir. We'll reach you soon again.
Sure. Thank you.
Okay sir. Okay. Priyanka, you can announce when we will be the next session
Yes.
and who is the next speaker.
Yes. So participants, we will take 10 minutes break, and our next session is from 12:45, but you all gather here by 12:40, and our next speaker is Dr. Vikrant Pateja sir. So you please take 10 minutes break and please come by 12:40. Thank you, participants. Thank you, sir.
Thank you very much sir. Okay.